talk about a little bit of a shift in what we've been talking about so far. It's going to be in a comparative analysis um, of looking at quantitative MRI tractography, and we're going to evaluate um, tubular retractor versus open spatula surgery, giving us a different look in the early phases of how to evaluate white matter tract um, conditions and injury. Disclosures are attached. I'm going to go a little bit into some of the background that's relevant to the study I'm going to present, and then go through the study and kind of future opportunities there. We all know cerebral retraction injury. It's an integral part of subcortical surgery. Oftentimes, this can present as a direct injury from direct pressure from retraction versus some indirect injury that comes from delayed ischemia or hemodynamic changes in the brain. When we talk about retraction injury, prior studies have looked at different modalities to evaluate this extent of injury, whether in the form of evoked potentials, metabolism, blood flow, or even extent of edema. With subcortical surgery, we're thinking about that damage that we're seeing is with the white matter tracts themselves, which we're all familiar with, but how they're damaged, how they're affected, where my study is going to start looking at some of the quantitative abilities that we have to kind of put numbers on the extent of damage that we're seeing in these white matter tracts or subcortical spaces. DTI, or diffusion tensor imaging, gives us a good idea of how to demonstrate the flow of white matter tracts. It measures the direction of the water molecules in a given voxel, and this gives us an idea of white matter tract trajectory. And these particular diffusion tensors, they give us a decent amount of data that we're going to start trying to extract some numbers from in the form of eigenvectors and eigenvalues and different orthogonal trajectories. From these diffusion tensors, you can group them together in DTI, and these are what we're familiar with, these suspected tracts in the white matter tracts that are in different forms, have different presentations depending on what image modality you're using. Over time, what we've discovered is from DTI, we're now starting to translate these DTI images into three-dimensional tractography, where we can get whole brain tractography, auto segment into specific white matter tracts. And not only that, we can isolate one or two or a group of white matter tracts to further evaluate what those white matter tracts are doing. And thus far, the majority of the time, this is being used by neurosurgeons in a qualitative manner, helping with surgical planning, understanding the orientation of your tumor to where the white matter tracts are, to help you with your surgical approaches. What my study tries to do is take that next step and look at some of that quantitative data that DTI is giving us to get an idea of whether we can determine the extent of damage of the white matter tracts. Certain applications have been shown to show quantitative tractography for different modalities. It's yet to be done with surgical or neurosurgical cases, at least that I'm aware of. For this particular talk, I'll be talking about some of the specific metrics I'll be talking about are fractional anisotropy, geodesic anisotropy, as well as radial, axial, and mean diffusivity, which I'll briefly go into so it will help with the understanding of the study. Fractional anisotropy looks at the directionality of water molecules through a region of space. An elevated FA can give you an idea that there's been some sort of damage, whether in the form of edema, demyelination, or some glial tissue damage, where the flow of water is not in a uniform state. A decrease in the FA often shows uniformity in water molecule movement, or no or little damage. Geodesic anisotropy looks at the measure of space between those diffusion tensors. It can give us an idea clinically about whether there's some type of mass effect or compression in the intraparenchymal space. With axial and radial diffusivity, we're looking more at the integrity of the axon itself. Axial diffusivity is looking along the trajectory of the axon, whereas the radial diffusivity looks at the perpendicular diffusivity of a given axon, again, giving us ideas about the integrity of the axon, the degree of myelination. Mean diffusivity kind of combines the two, looking at all three orthogonal viewpoints to give us, again, a good understanding of the axon track integrity. For this particular study, we used some of these metrics in order to evaluate the white matter tracks in patients in two different cohorts. One using tubular retractors in the form of the NICO brain path, and the other, which we're calling open craniotomies, uses the standard spatula retraction. We looked at 123 patients that had our specific MRI protocols for tractography over a 3-year period. From that, we took 10 tubular retractor patients who fit the criteria of being over 18, having subcortical lesions that's greater than 5 millimeters from the cortical surface, a solitary lesion that was an elective procedure with no significant comorbidities. We then paired these to a group of spatula retracting tumor patient, postoperative patients based on the tumor size, normalizing for tumor size, cortical depth, as well as the age. And our tractography software being used in this case was a Synaptive Modus plan. For our analysis, what we were using is, as you can see in figure A, we get the whole brain tractography. We then, in figure B, auto-segmented into the individual white matter tracks. And then we were only looking at the ipsilateral supratentorial components white matter tracks. So we'd get rid of any white matter tracks that are crossing midline, going in the infratentorial space. And this way we were getting a full idea of what the white matter situation was in the ipsilateral hemisphere. Our preoperative data showed similarities in the two groups when we looked at the age, gender, sidedness, as well as the Karnofsky's performance scores preoperatively. Pathology was similar, as well as the subcortical lobes that were involved. With each tumor, our tumor size, as well as the depth from the cortical surface, was also similar in the preoperative characteristics of the two groups. Looking at the clinical perspectives that we're often familiar with postoperative craniotomy surgeries, we did find that there was an improvement in the KPS of our tubular retractor group compared to our open surgical group, whereas the other postoperative issues such as seizures, motor deficits, length of stays, and tumor postoperative extent of resection and residual tumor volume were similar between the two modalities. When we start looking at the quantitative data, we find in our preoperative group similarities in the numbers, both in the anisotropies and the diffusivities. When we get into our postoperative views, we do see that we see less of a decline in the FA or fractional anisotropy in our tubular retractor group compared to the open group, as well as improvements in the geodesic anisotropy in our tubular retracting group, which gives us a sense that there's in the tubular retractor group, we infer that there's less abnormality or misalignment of the normal white matter tract flow, as well as less compression, probably in the form of edema that we're seeing in that proximal region of the parenchyma around our resection cavities, which gave us some of those numbers. Again, we did see less of a decline in the FA and improved GA or geodesic anisotropy, again, showing that it's likely that the tubular retractor was showing less neuronal alterations, less edema, and therefore compression, which gave us a little bit of those better results. This chart gives you just an idea of what we'd expect to find as far as the trend in the metrics when we do see damage in the intraparenchymal space. The thought process is in our left-sided figures that the tubular retractor gives less exposure to the proximal white matter tracts, putting them at less risk for damage, whereas the open craniotomies with the wider exposure puts a lot more of the proximal white matter tracts at risk for alteration, which is likely why we were seeing in this early stages of our studies, some of the differences in the numbers. For our diffusivity, or those metrics that look at the axonal integrity, we weren't seeing much of a change. There were little trends, but nothing of significance. I suspect likely when I used spatula retraction, I'm mainly using cottonoids to dissect between tumors and brains. The retractors normally for me, mainly just used for visualization at a superficial level, and I'm not very aggressive with spatula retraction, which is likely why a lot of that proximal parenchyma around the resection cavity didn't have as much kind of axonal damage as one might have expected. Thinking about some of the clinical correlations, obviously quantitative tractography is in its infancy. There's been some neurodegeneration studies with Parkinson's, Alzheimer's, that's looked at some of it, but nothing really in the cranial tumor surgery realm. In our study, we do see that things like KPS may have some associations with the anisotropy numbers that we're finding. Because these metrics do show us axonal integrity, as well as the white matter tract overall integrity, overall alignment, they do pose a possible or promising form of metrics to further evaluate white matter tracts. For me personally, when I make a decision about whether I'm going to use tubular retractor versus spatula retraction, I often think of when I'm going through any eloquent regions where the trajectory I have to either traverse or I'm in close proximity with eloquent white matter tracts, I'm often relying more so on the tubular retractor versus the spatula, and not so much as far as tumor size or depth guiding my decision making with that. Obviously, there's a lot of limitations with tractography in general, and certainly extracting data for the quantitative component. We have, which is our early stages of our study, it's a small cohort. With tractography data acquisition, there's a lot of issues that with just the acquisition of the data that can make it unreliable at times. Things such as edema or tumor infiltration can often, as you can see, knock out some of the white matter tracts, making it difficult to assess and visualize those white matter tracts. There's been several advancements with the technology, which has reduced a lot of this water edema knockout that we're seeing in this image. Also, things as simple as patient movement for the MRI acquisition can often alter that diffusion of water molecules and therefore alter what we're seeing as far as the suspected white matter tracts. That can also play a role in giving you misinformation as far as the tractography goes. There's multiple software modalities that look at tractography. Some of them are based off of algorithms of normal brain anatomy, and oftentimes when you have pathology that distorts the white matter tracts, these algorithms don't do a great job with accounting for those abnormalities or distortions from what they consider normal, which can obviously affect your data. There's also certain metrics, not the ones I presented today, but there's metrics like length and a white matter tract size that just vary from individuals, which can then just at the baseline make it difficult to compare one individual to another when dealing with white matter tract analysis. Again, the future is pretty promising for this study. It's in its very infant stages. Obviously, we're increasing our numbers to get a larger cohort of patients to look at. We're thinking about looking at a database, whether some of these metrics can present as, are there normative values for people, like where you have your normal levels of sodium or potassium? Can that be same as true for fractional anisotropy or geodesic anisotropy? So working on building a large database, looking at those numbers and seeing if we're seeing trends among a large population of patients. Obviously, the clinical correlation is going to be most paramount in this situation. Understanding how these metrics relate to neurologic function will be great not only for patient outcomes, but also giving patients an understanding of where their neurologic exam are based on imaging, what their prognosis may be. And we're currently working on just tractography in general verification studies. I'm looking at some of the cortical spinal tract motor mapping versus what tractography is showing, so we can get some real-time intraoperative data to validate a lot of the tractography data that we see in our studies. Great. And I thank everyone for your time. Happy to answer any questions that any of you may have.
Great, Dr. Eseonu. Very, very eloquent work. Thanks for doing that. Probably overdue. I think we have time for one or two questions or comments.
I'm really glad I didn't follow you. This is exactly what we need, right? So a couple of questions and then maybe to provoke a thought. A lot of what you're doing is comparing constraint boundary motion against diffusivity. So they're exactly the opposite parameters. When I look at the data, it's exactly what we hope for. The question I have is you did a lot for homogeneity scores of the patients. right? Have you done the same to create homogeneity scores for the preoperative imaging? So they're going to look very different. So here's the question. When you're looking at constraint boundaries for isotrophic versus anastrophic, it's the perimeter of the water motion and the eigenvector that will have some logarithmic to the lambda, right? In your equation. When we look at these tracks preoperatively, we can see that they can go from somewhere in between a totally anastrophic motion to somewhere in between. So track boundaries are present. What you showed is when they're present, they recover. And your KPS is lined up. Your diffusivity showed the opposite. The constraint boundary for the diffusivity is the surrounding tissue, which is the PIA, arachnoid, it's subpial invasion. Have you looked at that to compare we use a 2-to-1 ratio. So if your preoperative imaging shows that there's twice the amount of edema, it likely suggests that your PIA constraint boundaries are gone. Proton and water will diffuse at a different rate in that setting compared to it.
Yeah. So that's an excellent point. And again, I have not specifically looked at that. That's a part of kind of the large database that we're looking at, not only looking at kind of the normal anatomy that we're seeing, but also a lot of the pathologies, including edema and how that relates to the metrics. Because again, I think, and we put out a paper on some case report a while ago where we tried to normalize a lot of data, but I think the technology is getting better where we can kind of take a lot of the upfront numbers that we're seeing. But again, I think it just comes to more data is needed to kind of get a better analysis of what those metrics look like.
Yeah, I'm going to bet you that your geodesic diffusivity in a multi-parametric regression, looking at the ratio of edema will actually be statistically significant.
Yeah, I think so.